A very good morning to all of you. I am Dr. Suraj Pandey, Reader, Department of Periodontology, BBDCODS, BBD University. And today I'll be starting my lecture under the broad heading of acute gingival infections. Today we'll be studying about acute necrotizing ulcerative gingivitis. Now, coming to introduction. Well, infection. The definition is the lodgement and multiplication of a parasite in or on the tissue of a host constitute infection. It does not invariably results in disease. In fact, the disease is but a rare consequence of infection, which is a common natural event. Now, gingival diseases are a diverse family of complex and distinct pathological entities, which are the result of a variety of processes. The inflammatory response initiated in gingival disease appears to be a prerequisite for the destruction of connective tissue attachment apical to the CEJ. Now, the identification and treatment of gingival disease is an important step in preventing more serious periodontal ailments. Acute lesions have rapid onset and is accompanied by pain. Now, acute lesions by definition are of sudden onset, limited duration, and with well-defined features in contrast with the chronic lesions. Now, coming to the topic under question, acute necrotizing ulcerative gingivitis. Now, necrotizing ulcerative gingivitis, necrotizing periodontitis, necrotizing stomatitis are the most severe inflammatory periodontal disorders caused by the plaque bacteria. They are rapidly destructive and debilitating diseases and represents various stages of the same disease process. They are also referred to as ulceromembranous gingivitis, necrotizing gingivostomatitis, Vincent's gingivostomatitis, and trench mouth. It is characterized by the death and sloughing of gingival tissue and presence with characteristic signs and symptoms. Now, coming to epidemiology and prevalence. Now, NUG, abbreviation of the necrotizing ulcerative gingivitis, occurs often in groups in an epidemic form. During the World War I and II, the epidemics broke out among the Allied troops. Epidemic-like outbreaks have also occurred among civilian populations. That is why it is called a synonym of trench mouth. Now, in developing countries, the prevalence of necrotizing ulcerative periodontitis is higher than in the industrialized areas, and the disease frequently affects the children. In India, 54 to 64% of NPD cases occurred in children below 10 years of age. NUG occurs at all ages, with the highest incidence reported between 20 to 30 years of age. The disease seems to occur slightly more among the HIV-infected individuals. Studies among groups of HIV-infected individuals have revealed the prevalence of NPD between 0 to 27.7%. NP was found in 1% of 200 HIV seropositive individuals in a study, and the prevalence may not in fact differ from much of the general population. This is particularly true after the introduction of antiretroviral therapy for AIDS patients. So it's a controversy whether it occurs more in the AIDS patient or not. Now, coming to the etiology. The etiology includes the role of microorganisms, the role of host response, predisposing factors. They are the local predisposing factors and systemic predisposing factors. Now, coming to first, the role of bacteria. Now, two prominent scientists, Plot and Vincent, they introduced the concept that NUG is caused by specific bacteria, that is the fusiform bacilli and spirochetal organism. Lozich et al. Described a predominant constant flora and a variable flora associated with NUG. The constant flora is composed of Prevotella intermedia, the Triponema species, and Fusobacterium species. The variable flora consists of heterogeneous array of variety of bacterial types. Now, the bacteriologic findings have been supported by immunologic data from Chung et al. Reported increased antibody titers for spirochetes and Prevotella intermedia in NUG patients compared with titers in those with chronic gingivitis and healthy controls. Now, Borrelia gram-positive cocci, beta hemolytic streptococci, and Candida albicans have been isolated from the lesions of HIV-associated NUP. Now, it has also been proposed that human cytomegalovirus may play a role in the pathogens of these necrotizing periodontal diseases. Now, the pathogenic potential of a microorganism. An important aspect in the pathogenesis of periodontitis is the capacity of the microorganism to evade the host tissues. Among the bacteria isolated from the necrotizing lesions, spirochetes and the fusobacterium, they can invade the epithelium. The spirochetes can also invade the vital connective tissue. The pathogenic potential is these two is further substantiated by the fact that both of these fusobacteria and spirochetes can liberate endotoxins. Gram-negative bacteria liberate endotoxins in close contact with the connective tissue. Endotoxins then may produce a tissue destruction both by direct toxic effects and also indirectly by activating and modifying the tissue responses of the host. Now, through a direct effect, endotoxins may lead to damage of cells and vessels. Necrosis is a prominent feature of the so-called Schwarzman reaction, which is caused by the endotoxins. Now, indirectly, the endotoxins contribute to tissue damage in several ways. They can function as antigens and elicit immune reactions. They can activate complement directly through the alternative pathway and by liberating. They can also activate macrophages, T and B lymphocytes, and influence the host immune reactions by interfering with cytokines produced by these cells. Now, studies have shown that endotoxins can stimulate catabolic processes with degradation of both the connective tissue and bone induced by the released cytokines. Now, the extent to which such reactions contribute to the host defense or tissue damage is not yet known. Now, fusobacterium and spirochetes are found in moderate numbers of other oral diseases as well as in apparently healthy mouths, suggesting that predisposing factors are essential to development of ANAC. That means to say that only these two microorganisms are not sufficient to develop the disease. There are certain predisposing factors also required. The disease has never been produced experimentally in either human beings or animals simply by oral inoculation of materials from lesions in patients with the disease. A worker called as King, he also attempted to produce the disease in his own mouth by inoculation of infected material, but he was unsuccessful even after traumatizing the gingiva, and the organism promptly disappeared. But he did show characteristic signs of ANAC, however, after he became ill with several colds a short time later. So now this comes to the next important topic, the role of host response. Now, regardless of whether specific bacteria are implicated in the etiology of NUG, the presence of these organisms are insufficient to cause the disease. The role of an impaired host response in NUG has been long recognized. It is particularly evident that for HIV-infected patients, that the disease is associated with diminished host resistance. Among other predisposing factors, the basic mechanism may include altered host immunity. Changes in leukocyte function and the immune system have been also observed. NUG is not found in well-nourished individuals with a fully functional immune system. All the predisposing factor for NUG is associated with immunosuppression. Cohen et al. Described a depression of the host defense mechanism, particularly of the polymorphonuclear leukocytes in this disease. Total leukocyte count have been found to be similar for patients and controls. Patients with NUG shows a marked depression in PMN chemotaxis and phagocytosis as compared with control individuals. Reduced proliferation of peripheral blood lymphocytes has also been found in those patients. It was also suggested that elevated levels of blood steroids may account for the reduced chemotactic and phagocytic responses. Now coming to the local predisposing factors. Now it includes poor oral hygiene, pre-existing gingivitis, injury to gingiva, and very important, smoking. The disease may also occur in disease-free mouths. It most often occurs superimposed on pre-existing chronic gingival disease and periodontal pockets. The area of gingiva traumatized by opposing teeth in malocclusion also may predispose it to NUG. Pindborg et al. Showed that 98% of his patients with NUG were smokers, and that the frequency of the disease increases with an increased exposure to cigarette smoke. Systemic predisposing factors. It includes nutritional deficiency, debilitating diseases, fatigue caused by chronic sleep deficiency, psychological stresses, immunodeficiency, and other bad habits, oral health habits like alcohol and drug abuse. Now coming to malnutrition. Malnutrition results in lowered tissue resistance, the most common public health problem affecting the children who are most often affected by the necrotizing periodontal diseases. In response to the periodontal pathogens, phagocytes elaborate destructive oxidants, proteinases, and other factors. Periodontal damage may also occur often as a result of the imbalance between these two forces, antioxidants and host-derived anti-proteinases. Malnutrition is characterized by marked tissue depletion of the key antioxidant nutrients and impaired acute phase reactions to the infections. This is due to the impairment in the production of cellular action of cytokines. Malnutrition results in defective mucosal integrity and hormonal imbalance also. Malnutrition usually involves concomitant deficiencies of several essential macro and micronutrients and therefore has the potential to adversely influence the prognosis of periodontal infections. It also accentuates the severity of the pathologic changes when fusospiroketal complex is injected to the animals. Now, debilitating systemic disease may also predispose the patient to the development of the NUG. It includes chronic disease, for example, syphilis, cancer, severe GIT disorders like ulcerative colitis, blood dyscrasias like anemia, leukemia, and acquired immunodeficiency syndrome (AIDS). Nutritional deficiency resulting from debilitating disease may be an additional predisposing factor. Ulceronecrotic lesions appear on the gingival margins of hamsters exposed to total body irradiation. Now, coming to psychosomatic factors. Psychosomatic factors appear to be important in the etiology of AMIC. The disease often occurs with association with stressful situation, induction into armed forces, examination periods, emotional disorders, patients feeling inadequate at handling life situations, or inadequate coping, stress coping mechanisms. Now, psychiatric disturbance and the impact of negative life events will lead to activation of hypothalamic pituitary adrenal axis, HPA axis, resulting in elevation of cortisol levels. This may reduce the gingival microcirculation and salivary flow and enhance the nutrition to premolar intermedia, but also depresses neutrophil and lymphocyte functions, which facilitate bacterial invasion and damage. Significant correlation between the disease incidence and two personality traits, dominance and abasement, suggests the presence of AMIC-prone personality. The mechanisms whereby the psychological factors create or predispose to gingival damage have not been established fully, but alterations in digital and gingival capillary response suggestive of increased autonomic nervous activity have been demonstrated in patients with AMIC. Now coming to smoking, a very important local predisposing factor. The relationship between tobacco usage and necrotizing periodontal diseases appears to be complex. Smokers in general have a poorer oral hygiene than non-smokers. Smoking could also lead to increased disease activity by influencing host response and tissue reactions. As examples, smokers have depressed number of T helper lymphocytes, and tobacco smoke can also impair chemotaxis and phagocytosis of oral and peripheral phagocytes. Nicotine-induced secretion of epinephrine resulting in gingival vasoconstriction possibly is the mechanism by which smoking may also influence tissue susceptibility. HIV infection attacks the T helper cells of the body, causing a drastic change in the CD4 T helper cells and the CD8 plus ratio, with severe impairment of the host resistance to infection. Depleted T helper lymphocytes counts correlate closely with the occurrence of NUG, as demonstrated in the study of 390 US HIV seropositive soldiers. A complete absence of T cells in the gingival tissue of HIV infected patients with periodontitis shows the lack of local immune effectors and regulatory cells in the HIV seropositive individuals could explain the characteristic and rapidly progressive nature of periodontitis in these patients. Moreover, a protective effect has been encountered with the antiviral treatment of HIV infection and NPT, as well as HIV-associated gingivitis and periodontitis. Now coming to the clinical features. The NUG is an inflammatory destructive gingival condition characterized by punched out crater-like depressions at the crest of the interdental papillae, subsequently extending to the marginal gingiva and rarely to the attached gingiva and the oral mucosa. The surface of the craters is covered by a gray pseudomembranous slough demarcated from the remainder of the gingival mucosa by a pronounced linear erythema. In some cases, the lesions are denuded of the surface pseudomembrane, exposing the gingival margin, which is red, shiny, and hemorrhagic. The characteristic lesion may progressively destroy the gingiva and underlying periodontal tissues. On this figure, as you can see, the punched out characteristic lesions of the internal papilla. I will show you another cover with the pseudomembrane, right? Spontaneous gingival hemorrhage or pronounced bleeding after slight provocation are the characteristic clinical signs. A characteristic and pronounced factor, fetor XOR, is often associated with this disease, and also there is increased salivation. Oral symptoms. The lesion is extremely sensitive to touch, and the pain may often complain, and the patient may also complains of a constant radiating, gnawing pain that is often intensified by eating spicy or hot food and chewing. There is a metallic foul taste and an excessive amount of pasty or ropey saliva. Now coming to the extraoral signs and systemic symptoms. In mild and moderate stages of the disease, localized lymph adenopathy and slight elevation in temperature is the effect. In severe cases, high fever, increased pulse rate, leukocytosis, loss of appetite, and general lassitude. Systemic reactions are often more severe in children. Insomnia, constipation, GIT disorders, headache, and mental depression sometimes accompany the condition. In very rare cases, severe sequelae such as gangrenous stomatitis and NOMA have also been described as a consequence of ANAC. Now, stages in the progress of NUG as described by Pandey et al. Stage 1, by Horney and Cohen. Stage 1, necrosis of the top of the internal papilla. Stage 2, necrosis of the entire papilla. Stage 3, necrosis extending to the gingival margin. Stage 4, necrosis extending to the attached gingiva. Stage 5, necrosis extending to the labial and buccal mucosa. Stage 6, necrosis exposing the alveolar bone. And last, stage 7, necrosis perforating the skin of cheek. The lesions are seldom associated with deep pocket formation. Extensive gingival necrosis coincides with rapid loss of crestal alveolar bone. The gingival necrosis rapidly develops, and within few days, the involved papillae is often separated into one facial and one lingual portion with an interposed necrotic depression. The central necrosis produced considerable destruction and a regular crater is formed. At this stage of disease, the disease process usually involves the periodontal ligament and alveolar bone, that is necrotizing periodontitis. Further progression of the disease leads to involvement of the underlying bone, resulting in sequestrum formation. Also, the necrotic process beyond the mucogingival junction, the condition then is referred to as necrotizing stomatitis or NOMA. A very thank you all for your patient listening.